All right. Hi, everyone, and welcome back. We are in the final lap of today's conference. My goodness, it has been a lot of information shared, and just thrilled to continue these conversations. To close out today, we have a short, about 25 to 30-minute closing remarks from our 5 points panel. I hope everyone was able to join in and have a couple of, I've heard the discussions were quite robust, which is great. I'm glad everyone was able to have those discussions in the breakout rooms. So to close out today, I am going to go ahead and welcome Kim back to our stage to bring the rest of the panel up. All right, Kim.
Wonderful, thank you. Well, I hope you all had as much fun as I did. I had the opportunity to kind of bounce around a little, and I tried to join each of the panels for at least a bit, the breakout rooms. So it was great to hear the robust discussion. Thank you all for your questions and your engagement. So I'm going to invite the panelists, our 5-point panel, back to our stage here. And what's going to happen for the last 25-30 minutes of our day together is that we will go around the room with each of our perspectives and just hear some takeaways from how the conversation was, your discussions in your breakout rooms. What were some highlights, some topics that maybe got covered both times, some things that we didn't touch on during our panel discussion earlier. After we hear from each of you, we will also just have a few minutes at the very end to have some closing comments. Any topics that we didn't touch on today that you want to share with this group to make certain that we're thinking about, to really set the stage for tomorrow for the way forward. And as I shared with the panelists before we joined us here, we had a couple of conversations that questions in the chat that we didn't touch upon during our panel. I think probably a lot of those questions got answered, and those threads were probably woven through your breakout discussions. But one that we haven't talked about as a group is really the idea of health equity. And so I'm hoping that we can bring the day together, close ourselves up by thinking about, as we consider better ways to align incentives, how do we really do that to be sure that our healthcare system of the future, the one that we are all envisioning and dreaming of, is really an equitable one. So either if you can highlight any of that in your takeaways, or if that wasn't part of your conversation in the breakout rooms either, let's make sure that we touch upon that in your closing comments. So with that, I think I'm going to start with Peter, if I can, because I know that payer discussion there at the end was still going. So you probably have lots of things that are fresh in your mind from the conversation you were just having. So we'll hear from Peter as our payer, and then maybe just to give folks an idea, we'll go next to Alicia for some takeaways. So Peter, take it away.
Sure. So I think what I heard from the folks that were in our breakout, in the 2 breakouts, was sort of a recognition that, and a more full understanding of who's funding healthcare, and that the dysfunction or the multiple different systems and priorities that the healthcare system has in play may actually go back to the sources that we heard about earlier in the day, in the idea of an employer funding healthcare in order to have employee retention and growth. And as the employer contract with that employee changed over time, where I might have started out in the 80s, as working for an employer and saying, I'm going to be in this employer for the rest of my life. And thereby healthcare was a component of the contract with that particular employer. The decentralization of that compact, or the disintegration of that compact that took place, has affected sort of the healthcare decisions that are happening. So while employers continue to sponsor it, they may not feel the same obligation based on their employee turnover or whatever responsibility for the health of that particular population. Now, I think what's happened in COVID is that they feel increasingly responsible for it, and we'll see a movement away, and I've heard this from multiple different plan sponsors, is this idea of high deductible health plans did not serve us well and served us very poorly in the idea of a pandemic, in that the savings component of those high deductible health plans wasn't utilized, and there would be a movement away from that. As well as when we think about DEI, they're starting to rebuild the compact with their employees of how am I investing in your wellness, both socially and as an organization, to rebuild that contract between employee and employer so that you trust to work long and that I retain you as an employee longer, and thereby I have an investment in your overall wellness. That in the current environment, if I invest in it, you may leave and go to somebody else. I don't see the direct effect of it.
Great, thank you so much, Peter. Sounds like that was a really great discussion. Arlesia, how did the breakout go with the provider perspective? Share a little thoughts of your takeaways.
Sure, it went really well. I think we talked about a lot of things. What stands out to me was the conversation we had about really needing to look at primary care and looking at ways to better compensate PCPs and make it a more attractive field for providers to join. We talked a lot about centering our work in community and making sure that it's driven by those that we serve. And that can happen in a variety of ways. For example, looking at utilizing staff like community health workers, which is really low cost to the healthcare system, but provides a service in communities, in places that patients and families are familiar with, in a context that they want. And then we also just talked about also aligning health equity outcomes to incentives and ensuring that that is really embedded in the value of everything that we deliver as a healthcare system. But really, really good, robust discussion.
Sounds fabulous. As an ACO person, that is music to my ears. Community health workers and really putting the PCP at the center. I think as we were talking before about where do we put the power and where do we really sort of shift that, the decision making, the more we can make sure that we're aligning with the needs of the providers is great. I'm going to turn it next to Karen. Do you want to share some takeaways from the purchaser perspective?
Yeah, so we had, again, great conversations. And I think one of the things that came out in one of the questions was really about this idea of the time horizon of investment. If we look at healthcare costs as investments in health, and Peter's getting at that as well, what does that time horizon look like? And I will say that, our experience at the Alliance of working with our purchaser members feels a little different than this sort of description of that there's a loss of trust and that purchasers' primary interest has not been in health of their workforce, because in our experience, it's been very much that purchasers are really focused on benefit plans as a retention and attraction and retention tool, but really also share a strong interest in supporting the health and well-being, overall well-being of their workforce. So I do think that is a strong incentive. I think that the challenge that purchasers face is that the tools that are directly available to them to help them do that by virtue of plan design and others, there's limitations around that. And so I think, I think the question around incentives, I think of it as, or the way it's sort of sorting out in my head after all of these great conversation is who benefits from the intervention around health, whether that's a preventive service or a screening or something to make me better again, who benefits from that and over what time horizon do they benefit from it? And then who pays for it? And those are two very different questions, and they have incentives all over them, both of them, but you kind of have to unpack them, I think, a little bit differently. I will also say that while purchasers, I think, are huge, they represent more than half of the workforce or half of Americans through employer-sponsored insurance and almost half of the healthcare spending. I think they view themselves as not as powerful as they could be. And I think time has told us they're not collectively acting in ways that I think are really impactful to the system. And in fact, there was a national survey just recently that indicated, I believe it was 85% of employers really see a role for the federal government in shaping solutions. Didn't go so far as to say what those solutions should be, but that there is a role for that. So I think purchasers, while they want to maintain a voice in solutions around how to make healthcare better and really more focused on health on behalf of their workforces, I think they feel like they want to be part of a broader conversation to make that happen, and see, policy as playing an important role in that.
Thank you, Karen. All right, I'm going to turn it to Mike to share some takeaways from the patient perspective, and then we'll go to Sophia.
Okay, thanks. I think a lot of the takeaways, or a couple of the takeaways from the rooms that we broke out into were that a lot of people are curious to think about where the money goes, right? And how the money moves around, particularly like try to understand it from a patient's, particularly like a multi-chronic patient's perspective, but also and trying to understand what will drive different behavior, right? It's always about trying to behavioral change, and will co-pays change that, or this, and I think as we come back to what will drive behavioral change, there was a continued focus on, is the average person seeking healthcare a consumer or not? Right. And I think when we came to I've always come to the realization that patients are not consumers, right? And I think that many of my fellow the four other P's here, I guess, can I refer to everybody that way? Tend to think that we are consumers, right? And we will make that change, and whether you're a health plan or another type of thing, it's always about experience, and we can drive your change and behavioral change based on certain things, but that often when you really need healthcare, that those decisions are not made the same way, right? And money flows differently than we think it will be, and incentives necessarily don't align, right? And so that seems to be a consistent theme across the board. If I have to touch on equity, right? I mean, we didn't get to talk about it much in the breakout rooms, and sort of health disparities, right? Money flows is a big challenge, and how money flows. But one thing I didn't really hear, I think I heard one person just touch upon it now, but with community health workers, right? Which is, in order to incentivize people to take more active role in their care, right, and preventative care, it helps to be where people are, and who you can trust, right? So I think somebody else mentioned trust in the rooms I was in. Trust was a huge factor, right? And it didn't seem that it was that much of a factor in the larger group settings, but in the breakout rooms, trust was a major factor of that. And we talked about the loss of community providers, and the loss of community hospitals, and the loss of the local kind of doctor and nurse that you could see in the local practice, as a big challenge as to where money flows and where would you like to see it flow. So so I like that somebody just mentioned community health workers, right? So those were some big points that we touched upon in the breakouts.
Thanks, Mike. All right, Sophia.
All right, so we covered a lot of ground in the two sessions, but some of the key themes coming out were sort of what's the role and responsibility of the healthcare system, and what do we value? Like, what's our value as a society? What do we value in a healthcare system, and like what does that mean for how we then like organize and structure incentives and delivery a system, including what's the role of a consumer or a patient, an individual taking sort of responsibility over their behavior change versus, when does the system step in and create sort of that safety net to address the more systemic issues that might be driving people's health outcomes. We talked a lot relatedly about payment incentives. How do we design payment incentives to support addressing the social determinants of health? And we talked a lot about how who has the power, and that, my apologies for a screaming child in the background. We also talked about like distributing power and winners and losers as we think about shifting and changing incentives. And then one of the questions that we talked about in both breakouts was about, where should folks be focusing advocacy efforts? And I think I gave a few different answers, but I'll just say a couple of things here and hopefully tie in the equity question, Kim, that you raised at the beginning, which is sort of 3 policy areas for folks to be thinking about. One is addressing the underlying sort of prices of healthcare. Why are healthcare costs so high? What's driving that high and variable prices? And addressing the incentives that are creating and driving those high prices. The second is around sort of what are those new incentives that we want to look at? And I think there is hope, right? We know that when we start designing payment models around like global payment, population health payments, prospective capitated payment models, where we're moving away from fee for service, and we're giving providers the flexibility, a chunk of money, to be sort of simplistic about it, to think about like, how do I use these healthcare dollars to best meet the needs of my patient population, whether it's addressing the social determinants of health, whether it's doing more clinical care, whether it's sending a community health worker out to their home to treat them in home and assess their needs. That's sort of the direction that I think folks should be thinking about advocacy efforts. And then the third area is around like, what's the responsibility of the healthcare system around addressing health equity? And I think there is a responsibility and a role to be holding the healthcare system accountable for the impact of structural racism on the social determinants of health and people's health outcomes. And that I think is through 2 sort of overarching areas for folks to think about. One is around stratifying performance measures and equity measures by race, ethnicity, primary language, age. There's a very comprehensive list of sociodemographic factors that we need to be moving towards. And the second is around really creating that greater provider flexibility and incentives, especially for the safety net, the resources that healthcare providers and plans need to really build and staff relationships with social service providers, community-based organizations, that's going to allow them to allow them to coordinate services and better meet people's needs. So hopefully, I went a little bit beyond what we talked about in some of the breakouts, but wanted to just sort of wrap with that.
That's terrific. Thank you. Thank you, Sophia. All right, in our final just couple of minutes here, I'm going to turn it back to each of you one more time for some closing thoughts. Tomorrow is where are we going and what will we achieve? So if you can, using your perspective that you're representing on this panel, just share what's the advice that you want us to be thinking about as we move forward with this path. So I'm going to kick it off with our patient-centered focus, and I'm going to give it back to Mike. Everybody, if you can just do like 1 minute, 1 minute and a half, and then we will close up. So Mike, to you for your final thoughts.
Sure. Okay. So there were 1 or 2 things that I forgot also that I will mention that came up a couple of times. One of which was about informed consent, and does informed consent really exist in a choice of healthcare? So that was a surprising one to me. It came up again and again. And the other one was about data agency, which we talked about earlier in the panel. So data agency and data rights that continued to come up. I think, my takeaways or sort of my challenges to maybe the people who are attending tomorrow is, how do we maybe take a better multidisciplinary approach, right, to include all the stakeholders in these processes, particularly patients and families and communities that really aren't often at the table enough, right? When these incentives are designed, right, they're oftentimes designed without people, and so then maybe they're not utilized that well. I think also that digital health can really help in preventative medicine, and could be a great source for the future. But again, if we want to maybe think about equity a bit, data sort of holders being the next generation of wealth, like I mentioned earlier, data agency and data rights and really informed consent have to become a better part of this process. That there's no other way to think about it beyond that. That's I think my challenges for everybody tomorrow is data rights and data agency, and if we're going to push forward in this path. Thanks.
Thank you very much, Mike. All right, Arlesia, why don't you close us up with your own final thoughts from the provider perspective?
Well, this is the benefit of following right after Michael, is I underscore everything that he just said. But I just want to double down on emphasizing just thinking about equity and health equity in particular, including the social determinants of health and how all of that plays a role in ensuring that patients and families receive them and communities are thriving.
Terrific. Karen, I'm going to turn it to you next.
Thank you, Kim, and thanks to all of the panelists here and all of you who have hung with us through the end of the day. I think moving forward, I'm going to express to you what the Alliance purchasers hold as their priorities, because I think it really fits in the context of this conversation. Is one of the things I shared in our breakouts. But, first and foremost, it's having strong primary care. And I think that includes many of the elements we're talking about here. One we haven't talked about a lot, but integrated behavioral health. So that's one. How you get your care, whether it's in person or virtual, is certainly something we're all wrestling with and figuring out. And that's an important element of this, that access piece. But I think equity is another important consideration as it relates to primary care. And I will say that is wholly another sort of separate priority that our purchasers have sort of identified as something that they really want to address, something they have had a big wake-up call around. Not that this has not been an important priority for most, if not all of our purchasers, but I think the absence of data to help us understand equity issues in a healthcare setting is something that we're really facing. Stratifying measurement, stratifying all of our healthcare analytics around different views of equity and disparity, some of which are racial and ethnic in nature, some of which are just about poverty and really aligned with the social determinants of health. All are important, and we need to figure out how to incorporate those. We have to get a handle on rising costs, particularly around medications. And that relates to the fourth priority, which is transparency around prices and sort of how the funds flow and to whom, for what purpose. And then the last, I think, is really ties into a lot of the things we've talked about here as it relates to sort of, who's going to pay for the big expensive thing if you don't get the benefit from it. That's, really about linking coverage with evidence. If we link coverage with evidence holistically, we have to remember it's not just about the healthcare system. We also operate in the context of an insurance market. And that insurance market has the ability to pull levers that really will drive the incentives that will allow us to have a coverage, common coverage, so that I don't have to point fingers and worry about who's going to pay for it. We're all going to pay for it, and we're all going to share the expense the way insurance markets were designed to be. I may have taken more time than I should have, but thank you. I really appreciate it.
Thank you so much, Karen. All right, Peter, your final thoughts.
I think a lot of what's been mentioned already. So pushing the choice and the decisions of how I'm covered, how I'm working more to the individual. So where we see functional markets, regardless of funding in the senior space, and seeing the idea of private government payer partnerships in the way that healthcare is delivered, and then pushing individual consumers and members to participate in those choices seems to be working well in creating ownership on all parties in order to move forward. I think also the idea of primary care, medical home, not utilizing just based on when you're sick, but having a place where your data is housed securely, and where that data can be used for actions that are going to happen next in order to maintain your healthy position or move you to your optimal health state if you're in state of illness. I think the more we can do around that, that's a great place to go next.
Wonderful. All right, Sophia, final closing thoughts with a policy perspective.
I mean, I think I kind of laid out in my takeaways sort of the 3 areas where I think, folks should be thinking about, but I just want to echo everything that all my fellow panelist members have said, or particularly on primary care, social determinants of health, equity, integrated, behavioral health integration, like so critical to being able to achieve this sort of end state that we're all envisioning. And then the last thing I'll just say is we have a huge opportunity working across the 5 Ps right now with the new administration, with new members of Congress, to do some really important education and to sort of help usher them and push them in the right direction about where we think they need to go. Agendas are still being set, that it's not clear what exactly the agendas are around healthcare transformation. So just a big opportunity for folks to be thinking about that as as we see administrators taking their seat and staffing up on the administrative side. So just a good opportunity for us over this next period of time to be making real headway on sort of the direction in the future we think we need to go.
Kim, can I add something? I'm sorry.
Absolutely. Yes. Mike
so-
gets the last word.
I'm sorry. So I want to say something that I hope none of us will lose, right? Is that this comes back to a couple of things, right? Trust. Who can you trust? Who do you trust, right? And why do people trust the different Ps differently? Okay. And think I hope that all the Ps will kind of think about what they've done over the years or how they can move forward to regain trust or to have better trust. It's not always about data, right? And using data and analytics, right? It's not always about data. Like I know this data is the wave of the future, but it's not always about data. Data doesn't gain you trust. Okay. And on top of that, somebody else said it, and I would be remiss not to say it, is access, right? Until we the 5 Ps can agree on access and what access looks like and who has access and where you have access, that's always going to be a challenging component of preventative care, helping somebody stay healthy, right? And where they are, wherever they are, we have access people at the different Ps, right? People devoted to access. Those are all going to be really, really important parts. And the final component of it is, I can't stress it enough, is cybersecurity. If you don't understand it, people won't trust you.
Mhm.
If you prove it time and time again that you play fast and loose with people's data, that's you lose all hope.
I think that is a great place to end this day. Thank you all so much, the panelists. This was terrific. It's such a lot of fun to have this conversation, and we really appreciate Cambia Grove for bringing all of these important perspectives together. So thank you for all of the work that each of you do and the hat that you brought today. I'm going to turn it back over to Maura to close us out for the day and share what's going to happen tomorrow.
Fantastic. Thank you, thank you, thank you. This has been an incredibly informative and hopeful opportunity to hear everyone's different comments and positions and how we can work together. Thank you again, panelists. Kim, thank you for moderating and hosting. Feel free to turn off your cameras and we really appreciate all of your work and all of your thought process and sharing your insights. All right, so we had a long day today. It's been great to be with you all. Thank you for taking this journey with us. Tomorrow, 9 a.m., a couple of thoughts about tomorrow. So we'll see you back here at 9 a.m. When we see you back here, we will start with a fireside chat with Dr. Farzad Mostashari, the founder and CEO of Aledade. He will be joined by Dr. Marian Couch, who is our Senior Vice President and Chief Medical Officer at Cambia Health Solutions, and they'll be discussing the pathway forward. And where we go from here. Following that discussion, we have our partners at the Accountable Care Learning Collaborative. The ACLC is hosting concurrent peer learning sessions. So you will have the opportunity to choose from either the PAC Medical Group or One Health Vermont in a facilitated discussion. Information about those two are in your attendee guide, so feel free to peruse them now if you so choose. And then the last thing is, as we close out today, we would love to collect your feedback. Some preliminary feedback about today, this work. This helps us shape our future events and can help improve what we do going forward. It'll also help improve tomorrow so that we know if we're hitting all our marks or not. So I know it just popped up. Please take a moment to fill this out if you can. And with that, I just want to say thank you all for joining, and we'll see you back here tomorrow. All right. Thank you.